Welcome back. Today we'll be talking about rectal cancer. We will primarily spend our time talking about how the treatment of rectal cancer differs from the treatment of colon cancer. The main issue is going to be anatomy. The rectum is located in the pelvis, and most of it is extraperitoneal. The working space is tight, and it's in proximity to both the sphincter mechanism as well as some important organs anteriorly. Additional differences are that the depth of wall invasion of a rectal cancer greatly influences treatment, and we need to discuss some concepts that we didn't really talk about at all with colon cancer, that is, the distal and radial margins, and we'll spend some time on this. The extraperitoneal location of the rectum means that radiation treatments are now possible. We never radiated a colon cancer, but neoadjuvant or adjuvant radiation is now feasible and in most patients desirable. Many rectal cancers, in fact, are treated with neoadjuvant radiation treatment. And the location of the rectum also means that in some patients, local excision will be an option. Let's first remind ourselves of some basic anatomy in both the male and female pelvises. In the male, the peritoneal reflection occurs at the interface between the bladder and the rectum. The rectum is also in very close proximity to both the bladder, the seminal vesicles, and the prostate. It's not terribly uncommon for an anteriorly situated rectal cancer to involve these structures. The membranous urethra here is also at risk, particularly in an abdominoperineal resection. In the female pelvis, the peritoneal reflection occurs at the interface between the uterus and the rectum. Additionally, the cervix and the posterior wall of the vagina are in very close proximity to the rectum. Importantly, in females, the urinary structures are quite protected from both invasion or surgical injury. The rectum is located within the bony vault of the pelvis. In general, the female pelvis is broader, and this provides a better working space for the surgeon. A very bulky rectal tumor in a narrow male pelvis is a very difficult surgical challenge. Also take note of the pelvic floor. These muscles make up a big portion of the sphincter mechanism. And its proximity of a tumor to these muscles determine whether a sphincter sparing operation can be done or whether the patient would need an abdominoperineal resection. This is another view of the relationship between the rectum and the levator ani muscle. One of our chief jobs in our preoperative evaluation of a patient with rectal cancer is determining whether the tumor in any way impinges on this muscle. So here's a basic anatomy question. Where does the rectum end and where does it begin? The lower border of the rectum is easy to define. It's the dentate line. But the upper border simply depends on your perspective. There are multiple different definitions. The anatomist will define the rectum as where the tenei coalesce to become a continuous layer of smooth muscle. A radiologist would define the rectum as beginning at the sacral promontory. An endoscopist considers the rectum to be anything up to 15 centimeters from the anal verge. And a surgeon generally would define the rectum as anything below the peritoneal reflection. This generally is about 10 to 12 centimeters from the anal verge. Since we're all surgeons here, this is the definition that we will use today. A few additional anatomic points about the rectum. The first is that it has no well-defined mesentery. We'll talk about the mesorectum in some detail in the next slide or two. The rectum also has 3 infoldings, which are usually called the valves of Houston. The value to us as surgeons is that as we mobilize the rectum and we straighten out these valves, we gain additional length. And all of a sudden, a tumor that was pretty low in the pelvis with full mobilization can pop up quite a bit into our view. It's also convenient to divide the rectum into thirds. The lower rectum is generally considered to be 4 to 8 centimeters from the anal verge. These patients are at risk for having to undergo an abdominoperineal resection if the tumor is too close to the sphincter mechanism. Generally, middle third tumors, about 8 to 12 centimeters, can almost always undergo a low anterior type of resection. Upper third tumors are from 12 to 15 centimeters. These are generally intra-abdominal tumors, and they're not treated any differently than a distal sigmoid colon cancer. So we're really not going to talk about upper third tumors today. We'll spend the bulk of our time discussing the low and middle third tumors. I want to spend some time discussing the mesorectum. I think we need to know exactly what this structure is and how it works to do an adequate oncologic rectal cancer operation. The first thing to understand, it's not a true mesentery. And by this I mean, if you think about, let's say, the small bowel mesentery, this mesentery suspends the small bowel, and the mesentery itself is attached to the posterior wall of the abdomen. This mesentery has 2 peritoneal layers, and contained within it are the blood vessels and the lymphatics. Well, none of that's really true in the mesorectum. There's no peritoneal covering here at all. It does consist of fat and lymphatics. That's certainly true. But there's nothing suspending this mesorectum from the sacrum. Also, the mesorectum is circumferential. This picture here is really worth 1,000 words. The mesorectum is thin anteriorly and much more developed laterally and posteriorly. And the mesorectum is contained within this layer called the mesorectal fascia. The mesorectum is a thin fascial layer that totally surrounds the mesorectum. Although it's a thin layer, it does condense to form the lateral ligaments. The main point for us about this layer is that surgical dissection requires us to stay outside of this layer circumferentially. We'll talk about what is meant by total mesorectal excision in a few moments, but basically it simply means staying outside this layer and not letting our surgical dissection get into the mesorectum. The next fascial layer for us to discuss is the presacral fascia. In general, the rectum lays on top of this layer and is only loosely attached by some flimsy avascular attachments. These can be sharply divided without any blood loss. If we get in the wrong plane and get into the presacral fascia, we really have created a heck of a mess. This picture shows quite nicely the problem, we have these presacral veins and nerves underneath this fascia. And if you cut these veins, they retract into the bone as shown down here. This makes control of these veins extremely difficult. Our usual methods for dealing with bleeding, like cautery or suture ligation, simply won't work because the vessels have retracted. So what do we do with this problem? Well, the first thing would be pressure, lots of pressure, and perhaps some topical agents like Surgicel or gel foam and thrombin. If none of that works, there is a commercial product that basically looks like thumbtacks that can be pressed into the bone, and that is something to try if your facility has them. But like all things in surgery, avoidance is far better than trying to manage this problem. Waldeyer's fascia is a surgical landmark that we need to be aware of. It arises from the presacral fascia and fuses with the mesorectal fascia, so it seems to serve a suspensory function. The main issue for us is that we will have to divide this layer sharply to get adequate mobilization for low rectal cancers. If you try to blunt your way through this fascial layer, you really risk tearing the presacral fascia and the underlying veins. So the best thing is to know that you're going to encounter it, not be surprised, and deal with it appropriately. I'll mention de non-Vies fascia primarily for completeness sake. This is not a layer that you'll see with your eyes or even feel. I think of it as the capsule of the prostate and seminal vesicles, and the anterior dissection in a rectal cancer needs to stay above the mesorectal fascia, but it needs to stay below this capsule layer. If you get into the prostate or the seminal vesicles, the bleeding can be quite difficult to control and can be quite profound as well. The rectum has a very good blood supply. The blood vessels enter the rectum posteriorly through the mesorectum. The upper rectum is supplied by the superior rectal artery, which is the distal continuation of the inferior mesenteric artery. The middle rectum is supplied by the middle rectal artery, which comes from the internal iliac artery, and the lower rectum is supplied by the inferior rectal artery, which either comes from the internal iliac artery or the pudendal artery. The venous drainage simply parallels the arterial supply. The lymphatic drainage pattern of the rectum is primarily cephalad. The lymph channels follow the superior rectal vessels to the IMA and para-aortic lymph nodes. However, in the lower third of the rectum, there can also be lateral drainage into the internal iliac nodes. What to do about these nodes, if anything, we'll talk about in a little bit. The pelvis is loaded with nerves that primarily govern urinary and sexual function. Unfortunately, postoperative bladder drainage problems or sexual problems are an all too common result after rectal surgery. This is particularly common the lower the resection has to go. Adhering to anatomic precepts that we've talked about will help minimize some of these complications, but they're rarely ever totally avoidable. All patients with rectal cancers need to understand that these complications may well be unavoidable. Okay, well, I hope you spend some time reviewing the anatomy that we just went over. It really is the key to safe and oncologically sound rectal cancer surgery. The next topic we'll start on is preoperative staging. In rectal cancer, this is really important because there's a number of decisions that will be made as a result of this workup. Some things that we have to decide. Does the patient require neoadjuvant treatment? Would they be a candidate for a local excision versus any kind of radical excision? And if they do require radical surgery, could they have a sphincter-sparing low anterior resection, or would they need an abdominal perineal resection? Also, it's really important to ask patients about their continence before we get too involved in this. There's just no sense doing a very low anterior resection in a patient who does not have good preoperative control of their bowels. I think it is the responsibility of the operating surgeon to perform a digital rectal exam and a rigid proctoscopy on any patient referred to him or her with a diagnosis of rectal cancer. So my question to you is, what information do these exams provide that will help you guide your decision making? These exams provide a lot of very important information to us. The first piece of information is, what is the distance of the cancer from the anal verge? You may well have got a report from the endoscopist that says it's at 8 centimeters or 10 centimeters. But the fact is that flexible scope bends and bows, and these measurements are never accurate. But your finger in a rigid scope will tell you exactly where this tumor is. In addition, a rectal exam will help you assess mobility and whether this tumor is fixed to the sphincter mechanism or not. Another important piece of information is the relationship of the tumor to the anal ring. The anal ring is a palpable area that corresponds to where the levator muscle inserts and becomes the external sphincter. This is easily felt, and you can judge the distance from the lower end of the tumor to this ring. This again will help us determine whether this is a candidate for a sphincter-sparing procedure or whether they'll need an abdominal perineal resection. To do all of this accurately, you may need to take the patient down to the OR. So don't feel like that is something you can't do. Like with colon cancer, all rectal cancer patients should have a CEA level drawn preoperatively, and for just the same reasons. High levels are associated with a worse prognosis. Elevated levels that don't normalize after surgery suggest that there's unresected disease somewhere. And of course, post-treatment follow-up is dependent on CEA levels as well. The value of CT scans in rectal cancer is to assess for metastatic disease in the liver and the lungs. CT scans don't provide any useful information about how much of the rectal wall is involved, and they're not very accurate either in determining the presence of lymph node metastasis. MRI is an extremely useful and valuable study in rectal cancer. The information we get from this study will primarily be the information we use to determine whether a patient needs neoadjuvant therapy or not. The MRI is extremely valuable in looking for positive lymph nodes. It images the mesorectum and the mesorectal fascia extremely well, allowing us to evaluate the circumferential margin. It also can see an invasion of adjacent organs. The one place that MRI is weak is that it cannot reliably distinguish between a T1, that is a tumor that is located just in the submucosa, or a T2 tumor, which is going into the muscularis propria layer. Distinguishing between these two situations is important if the patient is a candidate for local resection. This MRI nicely shows several positive lymph nodes. This picture shows invasion into the mesorectum. So this would be a T3 type tumor. This picture shows a rectal cancer that is broken through the mesorectal fascia. The problem here is that this patient is likely to have a positive radial margin on resection unless they have a very good response to neoadjuvant therapy. This image shows an anterior rectal cancer that is now invading up into the posterior wall of the vagina. So this is a T4 tumor. And this image shows invasion of the prostate. The role of endoscopic ultrasound in the workup of rectal cancer has been diminished, and largely this tool has been replaced by the pelvic MRI. However, there is one role for endoscopic ultrasound, and that's for distinguishing between T1 and T2 tumors. When looking at an endorectal ultrasound, you can discern 5 different layers. For our purposes, the most important ones are these dark layers, which are the muscle layers. So the inner layer is the muscularis mucosa, the outer muscular layer is the muscularis propria, in between here is the submucosa, and this is how we distinguish between T1 and T2 tumors in the appropriately selected patient. So over here we have a T1 tumor, and you can see that this muscularis propria layer is intact. However, over here on the right, we've got the muscle layer here, and then all of a sudden we lose it. So this suggests invasion of this muscle layer by tumor. So if you're a T2, you're not a candidate at all for local resection. When we talked about colon cancer last week, we really did not have to talk about margins at all. But with rectal cancer, margins are a big deal. So how much proximal margin should we have? How much distal margin? And how much radial margin? The proximal margin should be at least 5 centimeters to remove all the draining lymphatics. In fact, we usually get much more than a 5 centimeter margin since we divide the superior rectal artery near its takeoff with the IMA. The distal margin is of far greater concern for us technically than the proximal margin. It must first be noted that a positive distal margin is associated with at least a 40% local recurrence rate and a decreased 5-year survival rate. So our goal as a surgeon is to get a distal negative margin. However, if we insist on too much of a distal margin, the number of patients requiring a colostomy will clearly go up. There was a time when it was felt that all rectal cancers needed a 5 centimeter distal margin. As you can imagine, most of these patients required an abdominal perineal resection. Nowadays, most colorectal surgeons will accept a 1 to 2 centimeter grossly negative margin as a compromise between low local recurrence rates and sphincter preservation. The circumferential radial margin is a new concept for us. We haven't discussed it in any of the other cancers we've talked about, but it's critically important to grasp this for rectal cancer. Basically, the radial margin has to do with how far the tumor is from our area of resection. A tumor that's broken through the bowel wall that is now into the mesorectal fat is a T3 tumor. We want to see at least 1 millimeter between the edge of the tumor and our resection margin. Sometimes an advanced tumor will go all the way out to the mesorectal fascia. We really can't get a better margin than that in that case. But if we do a poor operation and violate this plane with our dissection and get into the mesorectum and come across the tumor here, then we have a surgically created positive margin, which we definitely want to avoid. The radial margin in rectal cancer is every bit as important as the distal margin, and a positive margin is associated with increased local recurrence and decreased survival. Rectal cancer surgery needs to adhere to the principles of total mesorectal excision. What this means is that we need to find the correct planes. A rectal cancer operation needs to stay above the presacral fascia, but it needs to stay outside of the mesorectal fascia. Some surgeons speak rapturously of this plane and call it the holy plane. Adhering to these principles is the only way to achieve a negative radial margin. If we get into the mesorectum, we're going to leave lymph nodes and lymphatics and tumor cells behind. This operation is also associated with fewer local recurrences and improved survival, and there seems to be better post-op urinary and sexual functioning as well. This picture shows very well the concept of total mesorectal excision. Keep in mind that the mesorectum is a circumferential structure, and so this dissection needs to be done circumferentially. We are looking to stay just outside the plane of the mesorectal fascia until we reach the point where we want to divide the rectum. If we get in the wrong plane and start coming through the mesorectum, you can see how we're leaving lymphatics and potentially tumor cells behind. This will result most likely in a positive margin and a pretty high likelihood of local recurrence. This is just another slide showing the idea of total mesorectal excision. This slide does point out that it greatly reduces local recurrence rates. And keep in mind, the radial margin that we're talking about is the distance from the tumor to the mesorectal fascia. And we want at least 1 millimeter clearance. Let's talk briefly about the lymphadenectomy that goes along with the rectal cancer operation. In general, 12 lymph nodes is considered to be the benchmark. But since most of our patients get neoadjuvant treatment, usually there will be less than 12 nodes in our specimen. Some oncologists consider this to be a good prognostic factor, meaning a good response to neoadjuvant treatment. In general, we are going to divide the superior rectal artery at its takeoff from the IMA. If there are positive lymph nodes near the IMA, then we can divide the IMA flush to the aorta. One controversy is whether we should do a lateral node dissection, since for lower rectal cancers, lymph nodes follow the internal iliac. Japanese surgeons do this quite routinely for low-lying rectal cancers and report good results. Western surgeons have not universally adopted this at all. One approach that makes sense will be to re-image the patient after neoadjuvant therapy. And if there are suspicious nodes along the internal iliac chain, then they probably should be removed at the time of resection. One of the largest differences in the treatment of colon cancer and rectal cancer is the use of neoadjuvant therapy in rectal cancer. So here's a couple of questions to think about. What are the benefits of neoadjuvant therapy? Who should have it? And what are any potential disadvantages of this approach? The primary benefit of neoadjuvant therapy in rectal cancer is that it can greatly reduce the local recurrence rate. Historically, rectal cancer has had a high local recurrence rate of maybe 30%. Local recurrence is just a terrible problem in this patient population. They get unremitting pelvic pain from nerve involvement. If they've had an abdominoperineal resection, you can get tumor growing through the wounds. Ureteral obstruction and iliac vein obstruction are common, all manner of fistulas, and then pelvic sepsis from tumor and tumor necrosis. All these problems are devastating and have no good solutions. Some very radical operations have been done and described for this problem. Pelvic exenteration or sacrorectomy are procedures that are sometimes invoked to deal with the horrible complications of local recurrence. So if we can reduce the local recurrence below 30%, we're going to be doing our patients a great favor. Additional benefits of neoadjuvant therapy are that some patients can be converted from an abdominoperineal resection to a sphincter saving procedure. And since we're not radiating the anastomosis like we would in the adjuvant setting, there's less post-op anastomotic strictures as well. Most patients that we see will be candidates for neoadjuvant treatment. Some of the clear indications are patients with a T3 or T4 tumor on imaging, clinically node-positive patients on imaging. You can consider doing this for earlier stage tumors, even if they're node negative, if tumor regression will permit a sphincter sparing procedure. And the last indication would be if imaging suggests invasion of the mesorectal fascia or a threatened radial margin. So really, when you add it all up, most patients with a diagnosis of rectal cancer will be candidates. There are several potential disadvantages to neoadjuvant treatment. The first is that it delays surgery. Neoadjuvant therapy isn't curative. The only thing that cures patients of rectal cancer is a well-done operation. Neoadjuvant treatment takes about 6 weeks, and then the patient needs another 3 to 4 weeks to recover. So their surgery will be put off maybe close to 3 months. Another disadvantage is poor healing. The radiation is intense. They get a high dose. This can affect healing of the perineal wound if they need an abdominoperineal resection. Sometimes these patients will need a muscle flap to heal that wound. And lastly, since the anastomosis is prone to leaking, most of these patients, if not all, need a protective ileostomy, which will have to be reversed down the road. Another big difference between the treatment of colon cancer and rectal cancer is that there are multiple different surgical options for a patient with rectal cancer. So let's talk about local excision first. Who might be eligible for this? The criteria for being eligible for a transanal excision are listed below. I'll let you read them, but the basic idea here, of course, is that these are low-risk patients with no evidence of metastasis. This picture shows some of the concepts involved in a transanal excision. The main issue is the tumor needs to be within your reach. Generally, this is going to require the tumor to be within 8 centimeters of the anal verge. And you need to be able to get a 1 centimeter margin. The depth of the excision is into the perirectal fat. You can leave the defect open or closed. Closure would be best if it can be done tension-free. In the well-chosen patient, the cure rate is in the middle 80s. Having good retraction is absolutely key to these transanal excisions. One device that's pretty handy is this Lone Star retractor. There are several other approaches to transanal excision. This picture is showing something called transanal endoscopic microsurgery. Basically requires a very large operating proctoscope. It has several advantages with improved visualization and much better exposure. This allows you to get better margins and have less local recurrence. It also allows you to get lesions that are much higher up into the rectum. Of course, this is a procedure that requires specialized instruments and a fair amount of specialized training. Another step up on the complexity scale is something called transanal minimally invasive surgery. Basically, this is a laparoscopic approach. You can insufflate through this device. You have a camera, and you can excise polyps this way, or tumors. Again, this is going to require a lot of fancy equipment and a lot of specialized training. Unfortunately, most of our patients will have more advanced tumors, and they won't be eligible for local excision. So they will need a more radical approach. We'll first talk about the sphincter sparing procedures, which fall into two categories: the standard anterior resection, or often called a low anterior resection, and an ultra-low anterior resection, which is commonly called a coloanal anastomosis. The indications for this procedure are T2 or greater cancers of the middle and upper rectum. The main criteria for an anterior resection is that you can get a negative distal margin. These patients must also have adequate anorectal sphincter function, and this procedure can be done a variety of different ways: open, laparoscopically, or robotically. A couple of points about low anterior resection. We're looking for a 1 to 2 centimeter distal margin, but remember the radial margin is every bit as important as the distal margin in terms of local recurrence and survival. And so we need to respect the anatomic planes and excise the entire mesorectum. The pelvic nerves that govern bladder and sexual function start out laterally, and so we need to keep our dissection in the proper planes to minimize these kinds of complications. Invariably, the splenic flexure is going to need to be taken down to make a tension-free anastomosis well down in the pelvis. Unfortunately, this anastomosis likes to leak, and in almost all cases, a protective ileostomy will be required. Nothing has saved more sphincters than this EEA Stapler device. Before this device was invented, the vast majority of patients with middle or lower rectal cancers had to have an abdominoperineal resection. The pelvis just doesn't afford a very good working space for doing a hand-sewn anastomosis. So the stapler has just been a miracle in terms of being able to put bowel together safely in an area where you just don't have good visibility. This picture shows a very low anterior resection where you're making an anastomosis between the colon and the dentate line. This is a technically challenging procedure that unfortunately is associated with pretty poor functional results. It's technically difficult to get the colon down this low. Creating a reservoir is really next to impossible. You just don't usually have that amount of colon. And plus the colon is bulky, and fitting it into this space is a real challenge as well. So this operation is interesting, it's a curiosity, and really only performed in very specialized centers that have some experience with it. One issue with anterior resections is the need for a protective ileostomy. Since most of our patients will get neoadjuvant chemotherapy, these patients will need a protective ileostomy. There are some patients who have T2 cancers and clinically negative nodes that do not require neoadjuvant therapy. And so these are patients you might consider avoiding the ileostomy. However, if they have a positive intraoperative leak test, which is generally done after you make the anastomosis, you put some water in the pelvis, you put a clamp above your anastomosis, and then insufflate some air through a proctoscope. If you see a bunch of bubbles, you have a leak. You're not in a position to close that leak with sutures, and so a protective ileostomy is a good idea in this case. In any T2 lesion, if the patient has been taking immunosuppressive drugs like prednisone or possibly one of the biologic agents, they should have a protective ileostomy as well. When you get right down to it, the vast majority of patients will require this. It will be the exceptional patient that doesn't need it. Abdominoperineal resection is performed a lot less today than once upon a time. This is due for several reasons. Neoadjuvant therapy has helped, and of course the EEA Stapler has helped as well. But there are still patients who are going to require this operation. If the cancer involves the sphincter muscles, you can't save the sphincter and get a negative margin. In the same way, if the tumor is just too close, you can't leave the patient with a positive margin. In women, if you have an anterior tumor that involves the rectovaginal septum, that will be an indication for an abdominoperineal resection. And at the time of that operation, you would want to take the posterior wall of the vagina in continuity. And lastly, if the patient has poor preoperative continence, even if you could save the sphincter, there would be no good reason to do it, since basically you'll have given them a perineal colostomy. These images are showing the perineal portion of an abdominoperineal resection. In general, this will require two surgeons. One is working up above in the abdomen, and the other starts below. You'll usually make a circumferential incision around the anus. I like to start posteriorly, since that's safe. Your first landmark will be the coccyx. And then you continue your dissection medially and laterally, and you save the anterior portion for last. That's where the high rent real estate is, and you want to approach the important structures last. This slide just briefly sums up the treatment algorithm. Most patients with rectal cancer will get neoadjuvant radiation and chemotherapy. Then they get surgery. And if you've had neoadjuvant chemotherapy and radiation, you'll typically be recommended to have 4 months of FOLFOX chemotherapy. Now, these are the references for this presentation. In particular, 2 of these up-to-date articles are well worth your time to print off and keep. The one on surgical principles and the other on surgical techniques are really extremely well done. And a lot of the images that I used in this presentation, I took from them as well. Okay, that's a wrap. Next week, we'll start a new topic. We'll start talking about anal problems. We'll spend some time talking about rectal prolapse, and then a whole host of benign problems like abscesses and fistulas and hemorrhoids, all the fun stuff.